and we'll roll from here. As we said, the regional all-member call is in January. So we'll go forward from here. Oops, one too far. So please, a couple housekeeping items. Please mute your microphones during the presentation. Enter any questions you might have in the chat box, and share your experiences with the group and ask questions at any time. So we get you all to put your name, organization, coalition name and location, and activities and any other updates that you might have into the chat, please. Can everybody see and hear okay?
Yep.
Great. So we're going to have Ray Toppling talk a little bit about analytics, our combined regional data progress. And then Kyla is going to talk a little bit about vaccinations and the work that's been done ever since the pandemic, also leading into the 13th scope of work. We're trying to learn as much as we can about health equity and culturally and linguistically appropriate services. And as we look at this health equity, we wanted to talk about it today as our major discussion, and then also talk a little bit about where we're at. And we'll also look at how we'll be looking at this over the next 5 years. So we want to take a pulse check first. How can we support you? Coalition members, for those of you who are leads, please update any names or contact information, any additional or potential partners for recruitment to report. What are the most important areas of focus for your folks in your community? And for anybody new, we're looking at coalition participation agreements. And our next all-member meeting will be April 23rd. So anybody have any questions about any of this going forward? Okay. Our 5 goals remain the same as we work throughout the entire 5-year period. We're coming up in our last year now. Reduce opioid adverse drug events and death, chronic disease management, care coordination, emergency preparedness, and immunizations. We're doing great in a lot of these. We're still working on a few, and we've targeted them for some of the coalitions that we're working with. So you'll see these pop up a little bit more in the remaining time that we have left. So to get us started today, I'd like to introduce Ray Toppling, who's part of our great analytic team. He's got some data updates for us. Do you want me to stop sharing, Ray?
Yeah, I'll share my screen. So yeah, thanks for the intro, Mark. My name is Ray, and I'm a member of the analytics team here. Today, I'm going to be talking about 3 of the metrics that we have with the 12th scope of work in the task order 1 with CMS. And again, like Mark said, we're going to be looking at this at a regional level, so it's going to cover all 4 of our states and Pacific territories. So we'll start off with our first metric, and that is just 30-day readmissions. It's a pretty cut and dry metric. Over here in this bottom left, you can see this light blue line. That's our actual performance over time. So starting out at baseline, we have readmissions about 21.4 readmissions per 1,000 beneficiary years. Moving forward through time to the current state, we have about 17.8 readmissions per 1,000 beneficiaries. So we've got a really good long-term decrease here in readmissions. And I would like to point out one time period. This valley right here, if you will, that's really when COVID hit and people were very, very hesitant to go out and see anything. You know, at that point, when we were looking at this data, we thought, okay, we're seeing an artifact of COVID. And I'm pleased to say we've kept that readmission rate between 17 and 18 readmissions per 1,000 beneficiaries for about 3.5 years now. So really, I think it's a testament to the work that we're doing, the work that our partners are doing. and all those hospitals across our 4 states, keeping those 30-day readmissions down among that fee-for-service Medicare beneficiary population. So fantastic news there. The next metric we're going to look at is going to dive into chronic disease, and that's specifically going to be chronic kidney disease. So for this metric, our goal here is to screen for, diagnose, and manage Medicare beneficiaries with CKD and to slow that progression of CKD into end-stage renal disease. And what we want to see here is a nice upward trend. We want this rate to go up over time, and that is exactly what we see. Starting out at baseline down here, we've seen slow, steady increases, and really what that is telling us is that we're doing a good job of preventing beneficiaries with CKD transitioning into end-stage renal disease. There's 2 big takeaways here. One, end-stage renal disease is a very costly disease. It costs Medicare tens of billions of dollars every year to treat beneficiaries with end-stage renal disease. And 2, at the individual Medicare beneficiary level, that's a huge life impact. You know, your general well-being when you get end-stage renal disease versus CKD is huge. You know, dialysis and all that. So I'm pleased to say, again, we've got a metric where I can share some good news and say that we have some strong, steady upward trends here. And the final metric I'm going to look at is more of a nursing home metric. And it specifically looks at C. diff infections among short stay residents in nursing homes. Now, before we dive into this data, I'll walk you through a couple of other numbers. Across all of our 4 states and the Pacific Territories, we have about 500,000 fee-for-service Medicare beneficiaries. So if we take that 500,000 number, at any given time, approximately 8,000 are short-stay nursing home residents. Of those 8,000, I'm pleased to say, only 4 have recently been hospitalized for C. diff. So stepping down from 500,000 to 8,000 to 4 is really quite dramatic. And you'll see a little bit of volatility in this rate over time. Again, this blue line is our actual performance in this metric. Obviously, we want this rate to go down. We want to see less C. diff out there. That volatility is due in part to those small numbers. You know, 1 or 2 Medicare beneficiaries can start to swing this metric one way or another. But that being said, we still see a long-term downward trend in C. diff. And really, again, the credit goes out to our nursing home partners and our other partners out there who are trying to keep these C. diff rates extremely low. And in fact, we had one time period where there were 0. Obviously, that's the goal, but this is where we are currently. So I'll sign off by saying we looked at 3 metrics today, all of which have had some fantastic results. As much as I'd like to take credit for it, it's not me. I'm just the messenger. Really, the credit goes out to our partners. Without you, none of this would be possible, or it would be vastly more difficult to do stuff like this. So everyone on this call, if you're a Mountain Pacific employee or not, I think you share in some of the credit in some of this great successes. So with that, I'll hand it back to you, Mark.
Mahalo, Ray. Okay. So next up, Kyla, are you doing all right?
Yeah, I lost internet for a minute, but I think I'm good to go.
All right. Go ahead. Take it over then. Thank you.
It looks like I just need to be able to share my screen. Thanks, Mark, for the introduction. This is Kyla Newland up here in Alaska, and I'm just going to do a couple vaccine updates today. So one of the questions that's come up fairly frequently at some of our meetings recently is how effective is this year's flu vaccine? And so I wanted to just report out that what we saw in the Southern Hemisphere this year, which usually we will follow about 6 months behind the Southern Hemisphere with our flu season, we saw that the flu vaccine reduced the risk of influenza-associated hospitalizations by 52%. So this is really good sign for us that we have a good match for our flu vaccine this year. And I would encourage folks to get their vaccine if they haven't already. We did see peaks in Alaska several weeks ago and still continuing to see pretty high flu activity, not only in Alaska, but across our region. There's definitely areas of very high activity of flu right now. And then I also wanted to highlight something that I ran across that I thought was interesting. If we look at the comparison, are you folks seeing the chart from with the hospitalizations and the lines?
Yes.
Okay,
Yes.
thanks, Ray. So this is from the American Healthcare Association, and basically this is comparing flu and COVID, and RSV is on this chart as well. But just looking at the burden of hospitalizations, if we look at COVID versus flu and RSV, and it is significantly higher. And then also deaths are looking exactly the same. So just the disease burden of COVID is actually quite a bit higher than flu, which I'm not sure that everybody has kind of tuned into that yet. But we've gotten in this routine. We get our flu shot every year, and really we're going to get in the routine of we get our COVID shot every year, and it actually is affecting more folks as far as our poor outcomes. And then one last thing that I did want to share was another handout. Basically, it's kind of highlighting the same data, but it's looking at patients 65 and older and how they are at much higher risk for death from COVID, and then the disease burden, kind of comparing flu and COVID, and how if you are co-infected, you have a worse prognosis. And I will share the link to this in the chat for everyone if it's something that you might find useful to share. And I think that's all I have today, unless folks have questions. Thank you for participating today. We've got really good attendance. So thank you for all the great work you do across our region. And we're really happy that you partner with us at Mountain Pacific.
Thanks, Kyla. So you want to stop sharing? There
Yep.
we go.
I'll turn it back over.
Great. So next up, we're going to talk about class checklist. So culturally and linguistically appropriate services. I know that this has popped up quite a bit over the last 5 years, particularly after the pandemic, when we had a different look at populations of people. And a lot of it,
Very much.
seemed
We
that,
see your notes. So you have to
Right.
change your display settings.
excuse me?
We see your notes. So you have to change your display settings.
Oh, okay.
Yep. So
Nothing. Oh,
swap.
swap, huh? There you go. Is that better?
Nope, it didn't do it.
I
Hmm.
think maybe at the bottom you can click on one of those buttons.
Hmm.
Is the
Huh.
one next to the magnifying glass do? Over one. Not the magnifying glass, go to your left or your right. Nope.
Hold on. We'll stop
None of
sharing
those
and we'll
don't
try
do that,
again.
yeah.
Yeah. Oh. Let me try one more time. It's not working.
Would it happen to be under view options in the previous screen that you had?
I can't even move the screen back and forth right now. Oh,
Mark, is it in your PowerPoint presentation?
Hold on. Got it.
I'm happy to take over if Mary, if you could share the link.
I think Mary's going to take over.
Okay, all right,
Yeah.
sounds good. Thanks for your patience, everybody.
Yeah. Thank you, guys. So anyways, the look that we're giving going forward is a much more progressive look. So as we talk about health equity today a little bit, we're going to also talk about a checklist. Want to be really clear that this is not a test. This is not something that we report out on. This is an opportunity as we go into the next scope of work to identify where we're at in our communities, particularly the communities that Mountain Pacific is working at. And it will also help us direct some of the work that we're going to do going forward based on the health equity. So next slide, Mary. So class improves the quality of care, and it helps each organization become aware and responsive to each person's culture and communications needs. We have reported out quite a bit on a number of different health equity measures this entire scope of work, as I mentioned earlier, but it's going to be more robust going forward, and we're going to be looking at ways that we as partners can all work together to improve the communication and the work that's being done. The factors that we look at are cultural health benefits, preferred languages, health literacy, and communication. So next slide. There are national class standards. So these standards provide health organizations with 15 steps for implementation. The U.S. Department of Health and Human Services developed class standards for health equity, and this offers your organization's flexibility in choosing and implementing them over time. Standards are applicable to various professions and sectors. It's not just limited to health systems, but all of our different partners that are located in our communities that we work. Next slide. So there are principal standards and secondary standards. The principal standards provide effective, equitable, understandable, and respectful quality care and services, responsive to diverse cultural health benefits and practices, preferred languages, health literacy, and other communication needs. The secondary standards are divided into 3 themes. One is around governance, leadership, and workforce. The second is around communication and language assistance. And the third is engagement, continuous improvement, and accountability. Next slide, Mary. So we'd like to start out with a polling question today. Which of the following class resources does your organization currently deploy? A is to use real data to identify needs, describe current care. B is to collect real data from all individuals receiving services that you present. C is have created or implement a formal class plan. D is deliver or make available class-related trainings. And Five rather have completed an organizational assessment specific to language assessments. Hey, great. Give a few more minutes here. This is great. I think when we talked about this earlier in the year, it wasn't quite as robust as this. We didn't have quite as many of the boxes checked here. So it looks like we do need to work on creating and implementing a formal class plan. And more work needs to be done with class-related trainings. And these are the things, as we mentioned before, that we can identify as ways we can provide those services in the next scope of work. Okay, seems to have slowed down a bit. Let's go on, Mary. Okay. Implementation. So the National Class Standards Implementation Checklist will be sending out to all of you. You can select your organization stage of implementation. Please send back to us. From the list, you can choose what you're currently implementing, which gives us a little more of a drill down versus the sort of generic 5 topics that we just looked at with the polling question. What are you planning to implement and what you're not planning to implement at this time? Next slide. The implementation checklist itself talks about doing 4 different things here. One is to identify and designate a champion and create and implement a formal class plan, standardized procedures and scripts, and provide training. One way that we have found that's effective is to work with our patient and family advisory councils to help us with some of the information, communicating it, some of the language in some of the materials that we use, and also in some of the pictures or phrases that accompany the work that we're doing around the different metrics that we'll be tasked with during that time. And this helps us create better understanding out in the communities and helps make the groups of people that we work with a part of the chain of care, in fact, the first link of the chain of care. So that once we've gone through that, we can create and disseminate resources, class competencies, the age level of the reading of the information and how it's created, and then add these competencies and assessments into staff performance ratings, how well we're doing as a group and how we can improve upon some of the work that we're disseminating. We can provide incentives for financial or human resources for staff. Completing interpreter trainings, for instance, would be one. And the organizational assessment would be to assess language assistance services and tailor our evaluations for the people that we're working with, depending on how multicultural we are within the organization. Next, Mary. 5 through 8 talk about data collection, communication assistance notifications, community collaboration, and cultural brokers and partnerships. For data collection, we want to collect race, ethnicity, and language data. We know most of you already do this. Most of our talks previously and some of the other data we've captured in the past has shown that you're already using data to identify needs and improve care provision according to those REAL or real data. The communication assistance notification lets individuals of available assistance languages know that it's out there for them and that it's also free of charge. Communities, we collaborate regularly all members as part of this, but we have also individual coalitions by state, by zip codes. We want to collaborate with stakeholders and community members once we understand where we're all at with this health needs assessment and are able to identify how by coalition we could also work together on that. And then cultural brokers and partnerships. Want to utilize staff as cultural brokers and partner with community organizations for advisory boards and for help in different areas. I think many of us have found other groups that we're working with out there in the community around things like opioids. And we've also seen that we've been working with other cultural groups, Native groups, community health worker groups that actually provide other services that would also become very, very helpful as cultural brokers for us. Next slide. So what we like to see you folks do is take a focus and begin practices around objectives and timelines. So there are 3 different practices that you could take a look at and focus on implementing those and write these practices down along with a timeline for them. So practice 1, objective and timeline, practice 2, same thing in practice 3. So as you go forward, like I said, there will be a checklist. You can take a look at this and then you can identify your organization's focus as we go forward. Next, Mary. Implementing national class standards require concrete steps. So write them down, adhere to them, help your organization implement the national class standards. Consider when doing this, the objectives, challenges, staff and resources that can be leveraged for support. And take a look at the objectives again in terms of challenges, staff, and resources. Next, Mary. So in summary, culturally and linguistically appropriate services improve the quality of care by helping the organization become aware and responsive to each person's cultural and communication needs. And please use the National Class Standards Implementation Checklist to select your organization's stage of implementation. Also encourage your organization to adopt class for improved health equity and service quality. And once you've gone through your checklist, please return them to us so that we can report out where we are as a community, as a region, and how we're going to take a look at this and the work that we're doing in our future. Next slide. We do have some upcoming events that we'd like to make you aware of. Many of you already participate in a lot of these. There's our Worth a Shot series coming up, Breaking Barriers in Rural Health podcast series, and our next Regional Community Coalition all-member quarterly call will be April 23rd, 2024 for our states and April 24th for our territories. And you can register for this meeting right there. Mary's put it in the chat, so you guys will be able to see that. Next slide. We have resources and references. We've been updating them quite a bit. We've got the Centers for Disease Control and Prevention, CDC's Bridge Across program for vaccines. We're looking at zone tools and resources, tools also for chronic disease tools and resources. We have some resident information booklet, go to the hospital or stay. And we'll have the culturally and linguistically appropriate services checklist. Next slide, Mary. So I'm Mark Mirabella. I'm with the Mountain Pacific. So if you have any questions that we can't address right now, go ahead and send me an email. Next slide. So before we go to our next session, as we said, does anybody have any questions at all?
So Mark, the class survey, do we have
Yeah.
an online link to that, or is that a, like a PDF or a document that we would send out to folks?
We're gonna send it out as a PDF.
Okay, all right. I
Yeah.
just want to make sure if there was a link, we put
Yeah,
that in
good
the chat.
question. Yeah.
Okay, thanks.
Any other questions? Quiet group today. Okay. All right. Well, thank you all for your time today. We appreciate it. We will see you next on this all-member call on April 23rd or April 24th. And a number of different coalitions in our regions, our communities, and our states coming up here in February and March. So stay tuned. We'll keep you all posted. Thank you again for your time and effort today. And please take about the 15-20 minutes it would take to fill out that checklist and get it back to us. Mahalo very much for your time today.